Hello and welcome to Equity Practice, a podcast where we are learning together about health equity and how each of us can contribute to creating a world where all patients feel welcomed in medicine. Learning about health equity is an ongoing process and commitment to social justice, diversity, equity, inclusion, and anti-racism in medicine. Equity Practice is here to uncover the curriculum most of us were missing when we learned medicine. I'm your host, Emily Mathura, but you can call me Em. My pronouns are she, her, and Aya. With that, let's dive into the episode. You're listening to episode number 1 with Dr. Tonia Poteat. Dr. Poteat is an associate professor of social medicine at UNC Chapel Hill and the Center for Health Equity Research. After completing her PhD at Johns Hopkins, Dr. Poteat served for 2 years in the Office of U.S. Global AIDS Coordinator as the senior advisor for key populations. Since returning to academia in 2014, Dr. Poteat's research, teaching, and practice have focused on HIV and the LGBT health disparities, with particular attention to the health and well-being of transgender communities. With that, I would love to introduce to you Dr. Tonia Poteat.
I'm Tonia Poteat. My pronouns are she and her. I am associate professor of social medicine at University of North Carolina School of Medicine. And there I teach, mostly conduct research, and also provide clinical services for people living with HIV and precept students in the Student Health Action Coalition's Gender Affirming Care Clinic.
Wow.
I'm busy.
Yeah, you do a lot. So this podcast is all about creating an equity practice. Can you tell us, do you have an equity practice of sorts? What does that look like for you? And how does that show up in your work?
Oh, that's a great question. Do I have an equity practice? I don't specifically think of the way that I interact with people in terms of an equity practice, but I do think about all of the social and systemic structures that impact how and why people show up in an exam room to see me during a clinical visit. And when I think through what people's options are to manage whatever concern they came to the office with, I think about it in the context of the structures of society that are impacting that individual and what resources might be available to me to address those things.
Oh, that's
I don't know if that's an equity practice, but that's what I do.
No, I think equity practice shows up in a lot of people's lives in different ways, and it sounds like yours shows up in your work, and that's great. Can you tell us a little bit more about your journey with health equity and your work as a provider and how those things came together with research?
Oh, sure. I've been a PA for, this is aging myself, but well over 25 years. I came to practice as an HIV activist, actually. I was a member of the local ACT UP chapter. I had started an AIDS hotline specifically for women and was very much part of the social justice movement around ensuring care for people living with HIV, attention, care, research, those things. And have been providing care for marginalized communities ever since, and see it as part of a social justice, I guess one practice towards social justice has been my work as a clinician. I also saw that as limiting. So then after about 10 or 12 years in practice, I did more, I started doing more global health, public health kind of work around HIV as people in rich governments began making some investments in ensuring access to treatment for people outside of the United States. So I did a lot of that work and realized that there were many research questions that were not answered that were relevant to my work, that were social science kind of questions. And everyone seemed, at least that I was working with, was very focused on the biomedical aspects. So I went back to school to get a PhD in international health, focused on social and behavioral sciences, and have been doing mostly research with a little clinical care since then, trying to really integrate what we need to know about social sciences into how we provide medical care.
I love that. I'm so grateful for people like you who are creating the research that allows us to integrate social justice practice. It's surprising that we need that data-driven answers to make people feel welcome in medicine, but I'm glad that you're doing that. I wanted to highlight, you mentioned social justice as being a part of your medical practice, but you also saw
doing medical practice as being limiting. Can you speak more about where social justice fits into medicine and clinical care and why you saw it as limiting?
That's a great question. It's not limited by the individuals. My experience has been that most medical students that I've encountered and people in medicine enter it with a desire to do good things for other people. But they're doing good things within a structure that has been established on an inequitable foundation. And if you just think about beyond the sort of long history of medicine that we don't have time to go into,
Right.
there's just how medicine is structured. So we set our schedules from usually 9 to 5 or 9 to 7 or whatever. And then someone has to come to us during those times. And whatever they come to us with has to fit into the slot that we've allotted them for that time period. They can come if they can pay, or if they have health insurance, or if there's some special program that covers the cost of their care. So all of these things are set up like a business. It's
Yeah.
not set up like something that you have a right to because you're a human and you have a right to health.
Yeah.
So that's the structure in which we practice medicine, and it's a challenge to do so in a way that promotes social justice.
Medicine as a business is one of the hardest things I struggle with as a medical student, going into it, understanding that it's a transactional thing. And I think a lot of healthcare providers don't go into it. Well, I won't speak for everyone. Many that I know don't go into it thinking like, I want to make money. I want that transaction. They want that human connection. And, sometimes it's just not the focus. And so we end up getting very limited time with our patients, as you know, and it's sad. But anyways,
Mhm.
back to social justice. And I heard you say people living with HIV instead of HIV positive or something like that. Can you tell me why you use that verbiage specifically?
That has a long history in the HIV justice movements, and I think has been also taken up by many other movements. A big part of the disability movement is that we are all people. So we lead with people first, and we might be a person who's living with HIV or a person not living with HIV. We might be a person with a disability or a person without a disability, but we're all people. And centering that first helps to prevent reducing people to a diagnosis or to a condition or a symptom. And I think that's really important in medicine because we often take shorthands, and our shorthands sometimes remove the human part of the interaction that we're having with people.
Yeah, oftentimes I've found it's almost like it's a way to shield ourselves from the humanity, which I find really interesting. But thanks for explaining that. I think that's something that's coming more into the forefront, and using person first language is something that we're all adjusting to. So I'm glad you could explain that for our listeners. So the way I met you was through the HIV class at UNC, and you spoke specifically about a lot of things, but specifically about HIV care in the LGBT plus community. Is there anything that you want other healthcare providers to know about this community specifically, this type of care? Leave it at that.
About LGBTQ people or about HIV?
Both, and maybe the intersection.
Okay. I asked specifically because I know that there has been a movement to decouple HIV and LGBTQ communities. So there is a large impact of HIV on a subset of people who fall under that LGBTQ umbrella, but not everyone who falls under the LGBTQ umbrella is disproportionately impacted by HIV. Some are less impacted by HIV. So that's important to distinguish. And there are lots of other health inequities that need to be addressed in addition to HIV. So I always just like to put that out there because I read an article recently where they were talking about the current monkeypox epidemic, and they're just saying it disproportionately impacts LGBTQ plus communities. And I was like, it doesn't actually do that. It's a specific group of people who fall under that umbrella, but we're not all the same. Everybody who's LGBTQ plus is not all the same.
Yeah.
And so it's important, I think, as a clinician to understand who your patient is in front of you and not just sort of stereotypes or generics about them. At the same time that you try to understand the structures and the societal pressures that influence their lives and their health, also understand that this is an individual who is not just like a stereotype that got plucked out of the LGBTQ, array and is now labeled with all of these different, problems, conditions, concerns. So that probably didn't answer your question at all, but I just felt the need to say that.
That was really important. Thank you. You educated me on learning to decouple that in my mind, because I think it's always been taught as a coupled thing until the HIV class. So I appreciate you saying that and educating me. But back to the question.
So what would I want people to know about people living with HIV and providing care for people living with HIV? I would say, especially for people in primary care who are not doing sort of HIV specialty care, that people living with HIV, the cohort of people living with HIV, while there are plenty of young people, there are lots of people who are aging, having chronic conditions, and need primary medical care. So primary care clinicians are going to be seeing people living with HIV, and it's helpful to keep up to date on some of the sort of basics about living with HIV. And that's part of providing good care to our patients, not to see it as like, oh, HIV is over there.
Yeah.
And I think in terms of LGBTQ patients, I think that individualization is very important. So understanding sort of the history of oppression against LGBTQ people in the United States, that up until 2003, it was a crime to have a same-sex partner in the United States, not in some other country, but here. That the ability to marry was not guaranteed in the United States until 2015, and that for many of us, those rights feel precarious.
Yeah.
And that kind of oppression and social exclusion has impacts on someone's health. I mean, we're learning more and more about things like allostatic load and wear and tear on the body that come from those kind of stressors, as well as healthcare providers bring preconceived notions and stereotypes into their encounters with LGBTQ patients, often unconsciously. That might also impact their care. And then some people bring their very conscious bias, especially against transgender and gender diverse people who don't fit into the sort of boxes we're used to.
Yeah, can I ask you a question about that specifically in providing care to transgender folks?
Yeah.
How can you ask sensitive questions around sexual health that are trans inclusive, but also comprehensive? Do you have some scripts that you could share with me and our listeners about that we can use in our practice?
Absolutely. In fact, I just taught a class about this a couple of weeks ago. And I think what is useful to remember is that if you ask every person the same questions to start off with, questions that don't make assumptions about what their sex is, what their gender is, who their partners are, it allows the person to be able to share with you important information, knowing based on how you ask your question that you're open to hearing whatever the answer is. So that's sort of the premise underneath those questions. So in terms of just my first encounter with patients, I often just introduce myself like, hi, I'm Tonia Poteat, I'm a PA, I'll be providing your care today. My pronouns are she and her. How would you like to be referred to? What name do you want me to use? What pronouns when I'm documenting in your chart? And that's important too, because I'll be speaking to the person and unlikely to do so in the third person. So pronouns are less of an issue face-to-face, but we're in an era where everybody has access to their medical records, and we want to be consistently respectful and always. So making sure that we use the correct pronouns when writing about the patient and the medical record is important too. So that's just like a simple thing, just to say, hey, I know that you might not go by the name that's on your record. I know that you might have pronouns that are different from what people would call you based on what you look like to your average person. So I'm offering you an opportunity to name yourself and help me refer to you respectfully. And that can be for every patient all the time.
That's
and
great.
then when taking a sexual history, I sort of tweak. The CDC has these, I think they're called the 6 Ps for how to ask questions, partners, practices, pregnancy, those types of things. I tweak them to just make sure that they're gender neutral and open-ended. Tell me about your partners, or tell me about plans that you have for making a family.
Oh, I love
Being
that.
just really, really open so that people don't feel like they have to pick from a box that might not fit them.
Yeah, I've also heard of people having problems asking about what organs people may have, because we need to know, does someone have a prostate? Do we need to be doing prostate exams and checking for cancer in certain organs? So how do you ask which organs someone has?
That is a great question. And the place where I practice now, we have an organ inventory that's part of the medical record system. And often we'll just ask patients to fill out the organ inventory. But as you know, that can be challenging because health literacy can be low, and we use weird terms to describe body parts that people are unfamiliar with.
Yeah.
So I generally just say something like, it's really important for me to know what body parts you have so I can take good care of you and make sure that we're screening and treating the right parts. So I'm going to go through your body and ask you if you have certain body parts. And then I just do that. you know, do you have breasts? If so, were they surgically constructed, or did you grow them on your own or with the help of hormones? And, proceed that way through body parts.
Thank you. Yeah,
Sure.
That's super useful. I think a lot of people have that question and are afraid to ask it. So I wanted to make sure that we got that. Another question that I have is, what do you say to the person that goes, what are pronouns? Why are you asking that? And they just give you this nasty response. How do you face that?
I find that people worry a lot about that. And in 25 years of practice, I'm trying to think if it's ever happened. I don't think it has. I've never gotten a nasty response. I've gotten a surprise or confused, like, pronouns, that was like 30 years ago that I learned what a pronoun was. Like, people might not know those terms.
Yeah.
So it does help to say, I go by she and her. What do you go by? So I might use that instead of the word pronoun. How do you want me to refer to you? And people might go, well, obviously. And, for them, they feel like it's obvious. So that's great. And I say, well, I just ask everybody this question. It's a way of being respectful. And I just keep it moving.
Love that. Just pay no mind.
Yes.
So I'm a rotating medical student, which means sometimes I'm with a preceptor that may not have the same views as me. What can I say to a preceptor who says, why are you asking pronouns? I've had some of my classmates tell me they've had that experience.
I do want to say I have mad respect for medical students who have to navigate this land where they are more knowledgeable about what is sort of culturally competent than maybe the people who are precepting them. I know that is a power differential that's hard to navigate and can be a challenge. So I just want to say that before I suggest that it's super easy to just call out your preceptor. And not all preceptors are open to feedback. What I encourage the class that I just taught to do is maybe say to the preceptor, I just had this class, or I just listened to this podcast, and I learned that, one of the things that's important to do is to ask about pronouns, just in case it's not what we assume it is. And just present it as like, hey, I learned this thing. That sometimes, and you're a student, right? So your whole job is to be learning things, and just share with your preceptor, and, as a way to open the conversation.
I think that's a great way to go about it. I'm not sure if all preceptors would be open to it, but I think if they are, that's going to be the way that it comes about. So thanks. I also heard that using pronouns, the pronouns that a person has chosen actually reduces suicide rates. Is that true? And is that a fact that you would, you think I should cite to my preceptor, I guess?
It's not pronouns alone. Like at least the research that I have read has been about being gender affirming helps reduce suicide. So using the pronouns that someone wants you to use is one really important way of being gender affirming. Using the name that they want you to use, accepting how someone defines themselves and letting them be their authentic selves, whether it's about gender or anything else, as never harms people. I've yet to see harm come from treating someone, as their authentic selves that they tell you they are. But we do have data that indicates that doing so, especially for young people, is really important for mental health and can be life-saving and suicide preventing. So definitely sharing that data with a preceptor can be one way, assuming that we're all here to, help save lives and keep people healthy. Knowing that might make a difference for a preceptor who might think, oh, it's not that big a deal.
Yeah, this is maybe an unfair question because I didn't ask you to prepare this, but do you happen to know the study off the top of your heads if people wanted to look it up?
I know the author is Greta Bauer. I know it was published a while ago, the one I presented in class at least.
Okay.
And I can send you the paper
Okay.
if you want me to do that.
I'll link it in the show notes for people, and that would be great. I would love to see it and be able to better articulate it by reading it, I think. Yeah.
Well, there's a growing, but since she published that paper, there's a growing number of papers that look at mental health outcomes among people related to levels of gender affirmation. So you could probably just go Google Scholar and find a bunch of sources at this point, but she was one of the first people to get that kind of information out into the world.
All right, I'll check it out.
Sure.
Okay, so we're coming closer to the end. So I wanted to ask you a question from one of our listeners, which is, do you have recommendations on varying HIV screenings for different groups of people?
Okay. I think that this refers to current guidelines in the US that men who have sex with men should be screened more often than other groups for HIV and STIs. And I would say that has the potential to be stigmatizing, particularly for gay and bisexual men who are stereotyped in our society as having multiple sexual partners. There's nothing wrong with having multiple sexual partners. Part of the joy of owning your own body is being able to do what you want with it, in my opinion. Part of being free. But not everybody does have a lot of sexual partners, regardless of their sexual orientation. And so assuming that someone who has sex with other men has sex with a lot of other men is an assumption that can be stigmatizing and stereotyping. So I would recommend basing, as a individual provider, basing your assessment on your actual person in front of you. So if they're a gay man and they have been in a relationship with one sexual partner for a long time and have no other sexual partners, it doesn't make a lot of sense if they have no other sexual partners and their sexual partner has no other sexual partners and they are not sharing needles or doing other things that might expose them to HIV. It doesn't really make sense to screen them more frequently than you do anybody else for HIV. So it's a matter of like knowing your patients, with the caveat that often people don't feel comfortable, especially if they're new to you or if they're getting a sense from whatever they might be reading from you, accurate or not, that you're not a safe place to share their sexual health information. And it might have nothing to do with you. It might just be like, I'm in a health center. This is not where I talk about my sexual practices. They might not feel comfortable sharing. So sometimes what I'll do is say the recommendations are this. I want to find out what you think about that. And some people will be like, I haven't had sex in 30 years, or I've just been with this person forever. I don't need that. And then they make that choice. Okay. And then other people say, sure, that's fine. I'll do the screening.
Okay.
But leaving it in their hands to do, acknowledging that there are these guidelines, acknowledging that they don't fit everybody, and letting the person make a decision based on what they know about their own sexual practices without having to necessarily tell me all about it if they don't feel like it. Yeah.
So, and what factors do you think are the best for providers to think about when assessing risk for and meaning that someone would need more often screening more often? In my words.
That's a challenge too. I mean, there's the things that are in the guidelines, right? Like if somebody has multiple partners, that means that there's more opportunities for them to be exposed to a sexually transmitted infection as opposed to the same partner where they're having the same exposure. Someone who doesn't know the HIV status or STI history of their current partner, although I always thought that was kind of strange because you can know, and you know that the person has HIV. Maybe you're in a long-term relationship with someone living with HIV. So that piece of information, whether or not they use anything to prevent HIV, like condoms or pre-exposure prophylaxis, things like that are part of a risk, people call it a risk assessment to help determine who needs it. But I also did women's health for a long time, and women have been under-recognized in the HIV response for a long time in the United States in particular. And I saw plenty of women who had one partner and who also had HIV. And so those criteria don't always work for every person.
Yeah, that kind of brings me back to something you said before about how not every group within the LGBTQ plus community is at a higher exposure or at higher risk. Can you talk a little more about which groups are really at higher risk, which ones are not at higher risk, and does that matter?
Yeah, I guess I do want to answer your question, but I'm stepping back a little bit from depending on what lens you're looking at. So as a population health scientist, as a public health person, these sort of risk groups matter for research and interventions and tailoring things. But as an individual person provider, like as a clinician with one person in front of my office, I never want to assume anything about that person based on how they choose to describe themselves or how I might describe them to someone else. So I'm hesitant to answer that question in a conversation about one-on-one medical practice interventions with someone, because
Yeah.
I don't think it matters. I think what matters is who is in front of you, what do you know about them, and how can you take the best care of them, knowing that these like are potential ways that their health can be impacted.
Mhm.
And you'll know that based on your sexual history, and also on guidelines that really recommend that everybody be tested at least once, and most people annually if they're having sex. And that's for humans and not for necessarily risk groups.
Yeah. Wow, that's a great zoom out. I think that sometimes we need is that we see a lot of statistics in medicine, and we're supposed to take those statistics and apply them to the individual person that we're treating. And sometimes it can get lost that those statistics are humans and that the human in front of us is not just a statistic. So I think that was a really important point. So thank you for bringing that up. I have one more question that kind of relates more to your population health brain, and that is about the groups: men who have sex with men, women who have sex with women. What do you think about that? And do you think that's a useful grouping for risk?
Thank you for asking me that question. I might have been on a soapbox about that somewhere recently. I don't actually think those are helpful groupings. I think I have yet to find a person who labels themselves. Well, that's not true. In the US, people don't usually label themselves like, hi, I'm a man who has sex with men. They're like, hi, I'm gay, or I'm lesbian, or I'm bisexual, or I'm queer, or pan, or whatever like community label people use, which actually doesn't tell you anything about their sexual behavior. It tells you how they identify. And then asking somebody about, are they a man who has sex with men, or even the population, the man who has sex with men or a woman who has sex with women, all that tells you is the genders of the people who are having sex. It doesn't tell you anything about what those two people are doing. And what those two people are doing is really what determines their risk for acquiring an infection or transmitting an infection. And so I think, I use those labels in my public health writing because they are ubiquitous and nobody knows what you're talking about if you don't do them.
Right.
But they're also changing. I see more and more people saying gay and bisexual and other men who have sex with men. And depending on the context of what they're writing about, it might make sense. But I also see people doing strange things like saying men who have sex with men and women. And I'm like, so the men are having sex with men and the women are what? Just like womening. Like, what is you're talking about sexual health? I don't know who they're having sex with. Am I supposed to assume? And they do this particularly with transgender women, like men who have sex with men and transgender women. I was like, well, I know plenty of transgender women, and some of them have sex with women, and some of them have sex with men, and some of the men that they have sex with have penises and some don't, and some of the women they have sex with have penises and some don't. So I don't really know anything based on this label.
Right.
So you have to give me more information to help me understand what you're trying to do.
If we could erase that whole labeling system, is there a better way that you would propose we group people based to help us understand more about risk or population level health?
It's so interesting because I'm actually not a fan of getting rid of labels because I think people have created labels for themselves as a source of power. So before there was like this sort of gay umbrella that became the L, the G, the B, and the T, and a way of people who have sexual relationships that are unacceptable to society to come together under a label that they're like, I recognize you as somebody who is part of this group and might be mistreated by society or stigmatized. And in that, we can form coalition and power to make change. I think that is really important and shouldn't be dismissed, and it can be an important part of how someone sees themselves. as an individual, as well as part of community support and power. Where I think it becomes less useful is in a clinical encounter, unless we're trying to understand, for somebody who may or may not be out to friends or family, what kind of support system do they have to benefit their mental health? Or we have data that indicate that activism is a form of power that can be really enhancing to someone's sense of well-being. So it might be important there. So I just think we have to be more thoughtful about why we're using the labels and what they're supposed to be doing for us, as opposed to sort of throwing them all out. And that was a long answer to what was supposed to be a simple question.
No, I think it was great. Thank you. Well, we're almost out of time, so I have 2 more questions that I like to end the show with. First, is there any resources, books, TV shows, movies that you suggest if someone wanted to learn more about this topic, where should they go?
Absolutely. For more sort of clinical focused training, I would recommend the Fenway has I think it's the National LGBTQIA Plus Health Education Center. And they have a series of trainings available on their website on a variety of topics. The UCSF, University of California, San Francisco Center of Excellence for Transgender Health, also has a few trainings and resources on their website. If you're more of a I want to sort of understand more socially, I think one of the best, even though it's a historical TV series, the TV series Pose that had 3 seasons. You knew I was going to say this somehow. I loved it. It was my era, right? I was, around doing HIV care in that time period. So, but it's about community. It's not about HIV. It's about queer and trans people of color in New York City in a certain period of time and over time, and how they built community and family and supported and loved one another, and some of the challenges that they faced and how they got through them. And I think it can be a beautiful way to humanize and understand a community that's often marginalized and misunderstood. So I definitely recommend Pose. I love it.
I just finished it yesterday.
Oh, did you?
I cried almost every episode. Such a wholesome show on top of teaching. I learned so much about HIV, about the Black and Brown community, about trans folks and how they contributed to activism, and amazing show. That's all I have to say. Thank you for those resources. I'll definitely check those out, and I'll put links to the show notes for anybody who wants to find links to those. And the final question that I always end with is, equity practice is all about uncovering the small changes that we can all make to the way we practice medicine. Is there one thing that a listener could start doing tomorrow for their patients that would positively impact care? What would that be in your eyes?
Can I name 2 things?
Sure, I'll give you 2.
I think one thing, if people are not already doing it, the sort of simple introduction. Hi, my name's Tonia Poteat. I go by she and her pronouns. How would you like me to refer to you? What pronouns would you like me to use? Takes 2 seconds and opens the door for people to be their authentic selves in some way. And I think the second thing we could do is rethinking why and if we need to include someone's race in the medical record in the description. The whole 45-year-old Black man. I was like, why do I need to know most of those things? Thinking through, why am I saying this? What am I trying to communicate? And does it communicate what I'm trying to say? Or does it provide the reader with some sort of set of stereotypes that they can attach to those words that may or may not benefit their understanding of the patient?
Yeah. If you want to come back and do another show on race-based medicine, I would love to have you. Because that's
lots of opinions about that.
Well, thank you so much. I've really enjoyed having you on the show today. Is there anything else you want to add in these last couple minutes?
No, thank you for doing this, and thank you for bringing an equity lens to work that we do in structures that don't always support it, but that are really important.
Thanks. Well, we'll see you next time on Equity Practice, and until then, see ya.
Thanks so much for listening. Leave a comment with what you learned. And if you like what you heard, leave us a review wherever you listen to podcasts. If you want to be on the show or share with us someone who you'd like to see interviewed, let me know at equitypractice@gmail.com. See you next time.